Good afternoon and welcome to our GMed, a modernizing medicine company, MIPS 2018 update. My name is Dr. Julie Servas. I'm Medical Director of Gastroenterology, and joining me today is Ida Mantashi. Ida, would you like to say hi?
Hi, everybody. Thank you for joining us. My name is Ida Mantashi, and I'm going to help Julie through the slides today. And I'm a Director of the Compliance at Modernizing Medicine.
All right, so as many of you know, the quality payment program, there are two participant tracks. The first track is the merit-based incentive payment system, known as MIPS, or you can participate through the advanced alternative payment models, also known as advanced APMs. APMs are still, for the most part, not GI specific. You see a couple of the existing ones currently, but I will say that the Illinois GI group did submit Project Sonar Advanced APM to the CMS, or Physician Focused Payment Model Technical Advisory Committee. And that, a few months ago, did receive support to go to CMS. So what we are seeing in our community of gastroenterologists is that there are more APM models being proposed. And that one, as I understand it, will be in limited release. So who participates in MIPS? Last year was the transition year. In 2018, providers who bill more than $90,000 in Medicare Part B and have more than 200 Medicare Part B patients are able to participate in MIPS. The MIPS eligible clinicians include physicians, physician assistants, nurse practitioners, clinical nurse specialists, and certified nurse anesthetists. Exclusions are as follows. Those who are newly enrolled in Medicare, this is not a new exclusion, this has existed in previous years. The second box includes those who are low volume threshold, and for 2018 reporting year, Medicare Part B allowed charges less than or equal to $90,000 a year, or if you see 200 or fewer Medicare Part B patients, you can also qualify for the exclusion. In advanced APMs, if you're participating in those APMs, you are also excluded. There is a natural disaster exclusion as well. The hardship exception reweighting policy used to exist just for advancing care information performance, but now includes quality, cost, and the improvement activities. It applies to all 2018 MIPS performance categories, as I just said. You do have to submit an application. That's very important, and that application has to be submitted by December 31st of 2018. This slide is a little complex, so we're going to go through it step by step. This is an example of MIPS payment adjustment factors based upon final scores. So there is a composite performance score that each attestee will have. What you see on the x-axis is final score, and on the y-axis is adjustment factors. What we're trying to demonstrate here is negative adjustments and positive adjustments. And these, of course, are payment. The performance threshold on this diagram is a score of 15. And you can see that with the first arrow. Let me see if I can activate my arrow. Here we go on the screen. So if your composite score is less than 15, you will receive a negative adjustment from -5% to 0%. You'll see that as your performance score increases from 15 up to 70, you're going to have a modest positive adjustment a little above that 0% line that you see here. Here's 0% adjustment. What's important to note is that once you start exceeding a composite performance score of 70, you have positive adjustment, and then there's an additional adjustment factor for exceptional performers or high performers. So you can see a real takeoff in positive adjustment after a composite score of 70. So that's very important to keep in mind as you track your scores. This slide shows estimated payments for 2020. So recall that as you complete your attestations in 2018, CMS applies the adjustment in 2020, so 2 years later. What you see highlighted in blue are some metrics for gastroenterology. So in the first column, we have our MIPS eligible count. So we have approximately 11,300 clinicians eligible for MIPS. The Medicare spend in gastroenterology is about $1.2 billion. The percentage of clinicians eligible for MIPS is about 95.8%. Those eligible for the exceptional performance, so I just showed you that on the previous slide, that increased slope after a performance score of 70. Those eligible for the exceptional performance are estimated about 75%, so about 3/4 of us. The projected to get a negative adjustment is about 3% of MIPS eligible physicians. Positive adjustment would mean there's a pool of about 14 million to spread across those who are MIPS eligible. And then you can see the total dollars estimated for the negative adjustment. So this is just to give you a sense of the percentage of gastroenterologists who are eligible for MIPS, eligible for exceptional performance, and what that bucket of money looks like that can be applied to positive adjustments across all of us as gastroenterologists. So the MIPS category should look familiar to all of you. These are for 2018. Quality is still accounting for the majority of our final point score of 50 points. Cost is now being taken into consideration. And then we have improvement activities and advancing care information. Here are the changes for MIPS in year 2. On the left, you'll see information about 2017 if you attested during that year. And importantly, in year 2, let's pay attention first to quality. Previously, for quality measures, you provided 90 days of data, and the full year was optional. Now, you must provide data for 12 months. In 2018, as I mentioned, cost is now being considered for the entire year. And for improvement activities and advancing care information, it remains the same at 90 days of data. CMS is still trying to provide some relief to small practices. So small practices do get an advantage. There are 5 bonus points for final scores. There's a 3-point minimum that's provided for quality performance for less than 60% of data completeness. And I'll go into that a little bit more in a couple of slides. And there's a new hardship exception for small groups, and this is for the ACI category only. So let's take each category one at a time, and we'll start with quality, which represents 50% of the composite performance score. So what has changed in quality? 50% of the final score in 2018 is attributed to our MIPS quality measures. The data completeness requirement is now 60%. For measures that do not meet this data completeness standard, you'll earn 1 point. And this really is for large practices. The burden reduction aim, this is again CMS's attempt to provide some relief from the small practices. For small practices, if their measures do not reach data completeness of 60%, they will receive 3 points. So again, the large practices will receive 1 point if there's data incompleteness or less than 60%, but the small practice will receive 3 points. This is another couple important points. Improvement scoring in 2018 will be based on the rate of improvement. So your report of quality measures in 2017 will be compared to 2018, and you will receive points based upon that improvement. In addition, that second bullet point, up to 10 percentage points will be available to attesting individuals or practices in the quality performance category. So this is not a one-to-one, meaning if you improve 10% on a certain quality measure, you're not going to get all 10 percentage points. They will apply a total pool of 10 percentage points to your quality score, depending on your improvement on all of your quality measures. So small but important changes to quality reporting. So what stays the same for the quality rules? We're still selecting 6 individual measures. One must be an outcome measure or a high priority measure. There's no penalty for submitting more than 6 measures, and there's a maximum of 10 points for each measure. Bonus points for outcome and high priority measures still exist. This slide shows the ECQMs that are available within gGastro. You'll see the measure name on the left, the number in the second column, and whether it's an outcome or high priority on the right. Please note that when outcome measures are available, those should be selected. And the outcome measure for gGastro is controlling high blood pressure. You can also see the high priority measures are measure 130, documentation of current medications in the record. Number 238, use of high-risk medications in the elderly. And 374, which is closing the referral loop. And that's actually receipt of a specialist report. What's also important to note, and you may have seen this if you looked at benchmarks during the 2017 reporting period, is that the benchmarks are curved. And what this means is that you really need to choose measures where you can easily stand out from the pack. What you see in the diagram is a classical symmetric distribution on the left, the so-called bell curve, and on the right you have a negative skewed distribution. And the negative skew on the right, what that shows you is that there are fewer people on the left-hand side, and it's really much harder to stand out. You have to score a much higher score, do well most of the time to really stand out from the group. The next slide, we're going to walk through a couple of these. So again, the measure names, these are ECQM measures in gGastro. And let's just pay attention to the far right column where you have the 10th decile. What I want to call your attention to is in the middle, let me get my arrow here, documentation of current medications in the medical record. To be in the 10th decile, you have to do that 99.96% of the time. So you have to be pretty near perfect. And if you aren't, you're not going to be at the top of the pack and you won't be eligible as an exceptional performer, because basically CMS is saying to us, 100% of you should be documenting the current medications in the record. Compare this to a measure set right above it, which is preventive care and screening of BMI with a follow plan. 10th decile, the score is 85% or 86%. So you have a little bit more leeway in those patients that you're going to use this measure on. So just remember that these benchmarks are very important. If you have too many measures that the 10th decile is difficult to achieve in your practice, you may want to look at other high priority or outcome measures that will suit your needs. Of note, if you're looking at that second to last row, the use of high-risk medications in the elderly, the reason why these numbers look strange and the 10th decile is 0 is because this is an inverse measure. So in other words, we don't want to use high-risk medications in the elderly. So you want to really get to 0 as opposed to scoring 100%. You also want to pick measures in class 1 and avoid class 2 and 3. All of the gGastro CQM measures are class 1, so we are supporting obviously the best methodology for MIPS attestation. What class 1 offers are points in the 3 to 10 range. These measures have a benchmark, as we just saw on the previous screen. We showed benchmarks for all of those 9 measures. You need to have at least 20 patients or 20 cases, and you have to meet that data completeness standard. Recall several slides ago, we talked about this 60% data completeness standard that is applied to large and small practices. Classes 2 and 3, I think it's quite clear why you're only eligible for 3 points or even just the 1 point. Each of those categories, you either don't have a benchmark, you don't have sufficient cases, you're not meeting data completeness. And in terms of our track record on quality, this is just a screenshot from gInsights. And what you'll see is that there's real-time data on how our gGastro clients are performing in quality, advancing care information, improvement activities. And you can see a rough overall score. With our advisors, our gAdvisors helping with attestation, we've had 480 clients attest and 99% have reached their goal benchmarks. So we're very proud of the support that we offer to our clients.
All right, let's take a look at cost. So you all know that cost was 0% before. It is 10% this year. However, we're not totally unfamiliar with cost. Cost is what you knew a few years ago as value-based modifier. Let's take a look into what really cost contains of. It is 10% of your final score, and it will be 30% in 2019. So now remember that as cost increases, quality measure that Julie just went through it decreases. So if you remember last year, cost was 0% and quality was 60%. This year, cost is 10% and quality is 50%. And in 2019, cost will become 30% and quality become 30%. So the reason I'm going through this is because it is a very important portion of your score, will be a very important portion of your score. It's important to pay attention to it. It does contains two sections is Medicare spending per beneficiary and its total per capita cost per measure. So what is important to know that you're not required to submit any cost data to CMS. We get all the time that question that how am I going to, is it going to be through attestation? Is it going to be through submission? You are not required to submit cost data to CMS. CMS will calculate your cost data based on your claims. So for MSPB, it's important to know that only the cases which are minimum of 35 admissions are going to be calculated, meaning that you're going to have a patient that went to the hospital 3 days prior to admissions, stayed there for 30 days post-admission, and a minimum of 35 days been spent. In that case, that scenario will be calculated in your cost category. The other scenario is the cost per capita. That is assigned per your TIN number, which is TIN stands for tax identification number, and it's based on it. You know, normally the practice would have one TIN number. So the reason we put this slide here is because the QRUR is a report that CMS normally provides to you if you have been attesting through previous years. You are familiar with QRUR. Not everybody would look into it and would digest it really well, so that's why we are wanting to display it. This is just an example of the provider who did not have anything in Medicare spending per beneficiary. However, they did have per capita cost. And this is how their final number with the standard deviation would look like. It's important, if you have been submitted MIPS data in 2017 and value-based modifier before that, it is important to take a look at your report because it's going to help you understand where are the area that you can make improvements. So similar to quality, cost also has an improvement in scoring available into it. What does it mean really? It means that, if you look at your QRUR and last year, you've been considered expensive to CMS, or your costs been very high, and you made a major improvement, a significant improvement in 2018, you may be able to get up to 1 percentage point extra bonus for making the adjustment. It's also important to keep an eye on your cost benchmark periodically, because a lot of time everybody's asking, how do we get the cost measure? It seems to be that you will be able to actually call CMS and request it, and a dashboard obviously would reflect it if you have a connection to the CMS data. For 2018, they're not included in the specific episodes measure. However, there are a very good number of the episodes measures proposed. It is in draft for 2019. So take an eye on that and stay tuned to see which measure is going to come. I'm going to go ahead and discuss another section of the MIPS, which is the ACI. So ACI was 25% last year. It stands for Advancing Care Information. It's still 25% this year. So percentage-wise, it has been no changes since 2017. What has been majorly changed is the certification. So CMS gave us another year of flexibility with certification, which is really wonderful. What does it mean is that you will be able to submit your ACI for 2014 or 2015, or a combination of both of those. However, if you decided to submit for the full performance year, reporting, what Julie showed you before, it's for ACI is 90 days or 90 days plus. So if you decided to report the 90 days that it's within the 2015 cert category, you will gain 10% bonus for using the 2015 cert edition. I do receive this question all the time from providers that are saying, well, the 2014 sets are simpler and we would prefer to continue submitting 2014. That's okay too. There's no problem with that. In 2018, you do have that option. You can still select 2014 sets. However, you will not be qualified for 2015. Now, it is important if you are a provider who's switching between the EHR, you switching your current EHR who is in 2014 and you switch to 2015, another EHR which is 2015 cert, it's no problem. Don't be panic. You can still continue submitting your data. Okay, so a few things stays the same. A few things has been changed. Very minimum for ACI has been changed. So the basis score still is 50 points or 50%. Your performance score is still 90 points. There's additional bonuses available. Clinical data registry will give you 5 bonus points if it's addition to what you have been selecting. I'm gonna have a deep dive into that area so you can understand why does it say clinical data additional clinical data registry. And if you are reporting improvement activity which has the special cert credit, you will be qualified for additional 10 bonuses. And as we discussed it before, if you are submitting 2015 cert, you would get 10 additional bonus points. All right, so this is a screenshot of final rule. And we wanted you to know, I'm going to go through, what's new and what we had. So it's a comparison to what we had in 2014 certification versus 2015 sets of certification. A few things has been changed. Security risk analysis is a yes and no question. You're very familiar with it if you've been submitting meaningful use before, and also with the 2014 sets of the ACI last year. It's a set of questionnaires or procedures you normally do in the office to keep your data secure. It is a yes and no questions, and you know, it's our understanding from our providers a pretty simple one. E-prescribing is a important one because it is your basis score. So anything you see under required means that's part of your basis score. That means if you have a 0%, you will get nothing on the ACI category. You're gonna have to get above 0% for everything marked required. Patient access is really your patient portal. It's pretty simple to achieve. And then after that, patient education and VDT are part of your performance only. They're not part of the required categories. VDT is the difference between what was in ACI in 2017, 2014 certification sets versus 2015 certification sets. Secure messaging and patient-generated health data, they both are part of performance score. Send a summary of the care and request access summary of the care are required. So these are the challenging measures specifically for ACI. The reason is we hear that from our providers that not everybody they refer to has his address. And so it's important to have the directory and be able to identify who's the other party that you're referring to, and if you can get credit for that referral or not. Clinical information reconciliation, and at the end, immunization registry. This is where in the previous slide I mentioned that it's important to know that this was a slight change since last year. So 2014 would give us only 10% performance if you were selecting immunization. This year is a lot more flexible. If you don't do immunization, you can do either syndromic, electronic case reporting, public health registry, or clinical data registry. Now, if you did here clinical data registry, you're gonna get additional 10%, right? You're going to get 10% for performance. Now, if you have additional clinical data registry, you will get additional 5% bonus for that category. With the final rule, it was a nice surprise for exclusions. The exclusion did apply for 2017, and it's still valid for 2018. So CMS introduced two sets of exclusion. It's e-prescribing and health information exchange. Basically, if you have fewer than 100 e-prescription within the reporting period, you'll be excluded from e-prescribing. Majority of our providers are not into that category. They can't do the exclusion. However, you may be a part of the health information exchange category with fewer than 100 referrals. What is really important here is that once you select the exclusion, you will not get any credit for performance. So let me repeat that one more time. Once you select exclusion, there's no your denominator, numerator, your score met, not met will not be calculated. What does it mean? So if you are one of those providers who have 50 referrals and you have a pretty good score for health information exchange, you say you had 50 referrals and you are in 80% for health information, you still fewer than 100. So you still are eligible if you want to include exclusion, but your performance is up to 80%. So you're better off not to select exclusion and do report on that measures. Let's take a look at the other section of MIPS reporting, which was improvement activity. Improvement activity was introduced with MIPS in 2017. It contained 15% of your scores before. It stays 15%, so there's no change percentage-wise on the improvement activity. What has been changed is the additional activities are now available. If you remember that improvement activity in 2017 was only about 92 to 93 measures, and right now is up to 112 activities available to you. Remember that the minimum and high score are different, so there's like 10 points for the minimum and 20 points for the high score. There is up to 40 points available for large practices and 20 points for smaller practices. So this is another break that CMS has been giving for the smaller practices. Here's we list a few of the improvement activities that we believe is just simpler. gGastro has the ability to help you with submission of these improvement activities. The first column has the actual category, and then what way is it medium or high? As we discussed it, they have a different score. So if you're selecting each one of them, you're going to have to pay attention that if it's high or medium, because depending on high or medium, the high would give you more scores versus medium would not give you the highest score. And then we did discuss about the bonuses. So we said some of the improvement activities on the ACI. We said that there's an extra bonuses up to 10% when you select improvement activity, which is in the CERT EHR. So this is the column identifying which one is qualified for it, which one is not. For example, the care coordination is qualified for. If you select this measure, you will most likely get additional points on the ACI section, versus beneficiary engagement is not. And we continue with the improvement activities. Now this section is new improvement activities. These are, we excited about these measures. We think these are great measures in addition to what we had before. A few screenshots from gGastro to show you how we are using improvement activity. This is managed medication, and as you know, gGastro has one of the best medication reporting and queuing medications. So using gGastro would give you this option. And take a look at the patient portal. Patient portal would give you multiple additional improvement activities. If you are activating patient portal, your users are using patient portal, you'll be able to select any of those improvement activity in the left side. 24/7 access, advanced patient portal, fill up paperwork at home, and send messages, text result appointment, and education in order to get this improvement activity credits. So, we hear all the time CMS is saying that their focus is really on the patient, and it really shows through the measures that has been selected. I think Julie covered this MIPS Advisor services. I would like to mention one more time that we do have an amazing report and success stories out of our advisory services. We have approximately 280 participants in 2017 and 99% success. So I'm going to go ahead and with this information, show you the references, and we're going to open for questions. Yeah, the question I always get is that can we receive a copy of the PowerPoint? Yes, of course, the PowerPoint will be available through our website. Okay, the second question we are getting is that how does the submission work and what are the options for submissions? Submissions have different categories and different ways to submit. Currently, you can attest just like you did before with meaningful use for two categories, which is the ACI and improvement categories. And of course, qualities depending what do you use. If you are using the registry options, the registry would submit on your behalf. And if you are using the ECQM, you're gonna have to go to QPP submission page. I have another question that do lab tests calculate into the cost category? I do not know the answer to that question, so I will get back to you. I will look into it and let you know if the cost category. Again, you know, since cost is kind of new this year, we don't have all the data, so I will reach out to answer you back with that question. All right. Again, yeah, we have another question asking us about the cost submission. Just wanted to, I think I just mentioned that during the webinar that cost, you're not required to submit cost. It will be calculated by CMS. So cost is based on your Medicare versus the other category. You have to submit all the data. Although the cost section is only calculating your Medicare cost. All right, I don't see any other questions. If you do have any other question, please reach out to either Julie and myself, and we'll be happy to answer any question. Thank you for joining us today.
Thank you very much.
Bye.